Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr.Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. Today we are going to talk about a very fascinating clinical topic, the clinical localization of sensory abnormalities, the indispensable concepts. The clinical localization of sensory disturbances, the indispensable concepts. It is actually a joy of sensory disorders localization clinically. But before we go to the actual clinical localization of sensory disorders, we need to understand certain basic concepts. The sensations are basically two types, the primary sensations and the cortical sensations. The primary sensations are those sensations that are perceived from the level of the receptor root till the level of the thalamus. These sensations are called as primary sensations, namely touch, pain, joint position, vibration sense. These are all the primary sensations. The sensations which are perceived from thalamus to the parietal cortex, the thalamocortical fibers or the parietal cortex, we call that as the cortical sensations. They are tactile localization, 2-point discrimination, Graphistisia, Stereognosis, and bilateral simultaneous stimulation, that is extinction or neglect. So we have primary sensations and cortical sensations. So if the primary sensations are present but cortical sensations are lost, that means the lesion is in the parietal cortex. Cortical sensations are those sensations that are perceived by cortex, that is parietal lobe. As simple as that. Now let's check out on the primary sensations. The touch can be poorly localized touch or a well localized touch. Poorly localized touch is carried by the spinothalamic tract and well localized touch is carried by the posterior column. The second important sensations are pain and temperature sensations. Pain and temperature sensations are carried by the spinothalamic tract. They are small fibers, A delta fibers or unmyelinated C fibers. Then we have the joint position and vibration sense. These are carried by the posterior column tract. They are large fibers and A delta fibers. They are well myelinated fibers. Since they are well myelinated, the conduction velocity is very good when the large fibers and the myelinated fibers are intact. So spinothalamic tract are small fibers and they have lamination. Spinothalamic tract, as it ascends, it crosses over to the opposite side and then ascends and goes to the level of the medulla oblongata and thalamus, from the thalamus to the parietal cortex. So as it ascends, it crosses over to the opposite side. So what happens now? The lower limb fibers, as they cross, they become the lateral most and the upper limb fibers become the medial most. Very important. The lower limb fibers of the spinothalamic tract become lateral and the upper limb fibers become medial. So now if there is any extraneous compression coming from outside the spinal cord and hitting on the spinal cord, the lower limb fibers are the first to get affected and there is sensory sensations lost. Sacral sensations are lost. If it's an intramedullary lesion within the spinal cord, the leg fibers or the sacral fibers are last to get affected. So sacral sparing is present. So very important, in spinothalamic tract, lower limb fibers are laterally placed and upper limb fibers are medially placed. Posterior column, these are large fibers, well myelinated fibers. They do not cross over to the opposite side. They keep ascending and at the level of the medulla oblongata, they cross over to the opposite side. So here the upper limb fibers are laterally placed and the lower limb fibers are medially placed. And then finally we have the facial sensations which are carried by the trigeminal tract, especially the pain, the lateral medulla, which crosses over and then joins the spinothalamic tract. So we have the posterior column carrying the joint position, vibration and well localized touch. We have spinothalamic tract which carries pain and temperature and poorly localized touch. We have the trigeminal tract in the brainstem carrying the facial sensations, especially the lateral medulla. Right. Cortical sensations. Tactile localization. The precise location of the touch is known as tactile localization. 2-point discrimination. When 2 points are applied on a surface and the 2 points are appreciated as an individual 2 different points, you call that as 2-point discrimination. The fingertips and the lips are very sensitive. In fact, as less as 3 millimeters distance can be appreciated as 2 different points on the fingertips. Why the 2-point discrimination is great in fingertips and the lips? Because the sensory representation in the cortex, the point-to-point representation from the parts of the body to the sensory cortex is not according to the quantity. It is according to the quality. We keep using our fingers, we keep using our lips. So the sensations, the representation is largest for hand, for face, arm. It is less in trunk and less in the legs. So the highest is in the face and the hands, so the lips and the fingertips. That is 2-point discrimination. Bilateral simultaneous stimulation. When we stimulate bilaterally simultaneously, for example, if the right parietal lobe is affected, it will neglect or extinct the sensations which is used to test on the left side. That is known as extinction or neglect. And then we have Graphistisia. If someone writes a number on a person, even if the person closes the eyes, the person should be able to tell the number which is written on the skin. This is known as Graphistisia. Stereognosis. Even with closing the eyes, if a person is given a keychain or a small box, by just appreciating the feel of the keychain and moving it, he should be able to tell whether it's a keychain or a table, even without a small box, even without opening the eyes. This is simultagnosia. So the sensations, basically 2 types. The primary sensations, the touch, pain, position, joint, vibration sense, which are carried by the spinothalamic tract and the posterior column from the level of the receptor to the thalamus. And second is the cortical sensations, which are carried from the thalamus to the parietal cortex, which are tactile localization, 2-point discrimination, Graphistisia, stereognosis, and bilateral simultaneous stimulation. Right. These are the basic concepts of sensations. Another important concept regarding to nerve conduction studies. When we do nerve conduction studies, we can find out whether it is a demyelination, that is the myelinated fibers are affected, or axonal. If it is an axonal neuropathy, the amplitudes are lessened. If it is demyelinated neuropathy, the conduction velocity gets decreased because the saltatory conduction of the myelinated fibers gets decreased. But a very important point of nerve conduction studies in relation to the sensory abnormalities are that if the lesion is proximal to the dorsal root ganglia, the sensory nerve conduction studies are normal despite sensory loss. So dorsal root ganglia is very important, whether the lesion is proximal to the dorsal root ganglia or distal to the dorsal root ganglia. If the lesion is distal to the dorsal root ganglia, the sensations are lost and the sensory nerve conduction studies are also abnormal. But if the lesion is proximal to the dorsal root ganglia, the sensations are lost, but the sensory nerve conduction studies are normal. Very, very important, indispensable concept. Second important point is nerve conduction studies do not evaluate the unmyelinated or less myelinated fibers. They evaluate only the large myelinated A delta nerve fibers. Right. Now, how do we test these primary sensations? For pain, we use pinprick. For temperature heat, we use warm metal object. For temperature cold, we use a cold metal object. For touch, we use cotton wisp. For vibration, we use the tuning fork 128 Hz, and for joint position sense, we passively move the joints of specific, we passively move passive movements of specific joints. For example, big toe, we move it up and down. The person with closed eye should tell whether it's up or down. If he makes mistakes, we have to come proximally to the ankle joint, and then if he makes mistake, we have to come still more proximally. We need to understand certain terminology before we embark on clinical localization of sensory abnormalities. Paresthesias, dysesthesias, hyperesthesias, hyposthesias, allodynia, and dissociated sensory loss. Paresthesias are abnormal sensations which are perceived, but usually the pain stimulus is exempted. They are more like tingling sensations. So they are abnormal sensations, example tingling except pain. Dysesthesias are also abnormal, uncomfortable, but often unpleasant sensation, but this includes pain. So paresthesias, usually they are abnormal sensations, but pain is not included. Dysesthesias are abnormal and unpleasant sensations, but pain is included. Hyperesthesia is increased sensitivity to painful stimulus, and hyposthesia is a decreased sensitivity to painful stimulus. Allodynia, very interesting phenomenon. Allodynia is the non-painful stimulus being experienced as painful. So allodynia is a non-painful stimulus being experienced as a painful stimulus. And dissociated sensory loss, very interesting. Dissociated means going away, associated means coming together. So dissociated sensory loss means one particular type of sensations are present, the other particular types of sensations are absent. So dissociated sensory loss, pattern of neurological dysfunction of a single sensory tract. For example, spinothalamic tract. Classic example is syringomyelia. As I said earlier in my discussion, the syringomyelia, the spinothalamic tract crosses immediately over to and then goes upwards, ascends. So it traverses the spinal cord. So if there's a central cord lesion like syringomyelia, it affects the crossing spinothalamic tract but spares the posterior column, which does not cross at the level of the spinal cord. So the sensations carried by the spinothalamic tract, mainly the pain and temperature, are affected, but sensations carried by posterior column, touch, position, joint, vibration sense are intact. So here is a person who is able to appreciate the touch sensation, but if a person unknowingly or keeps the hand in the fire, he is not able to appreciate the pain stimulus. So if that is the kind of history forthcoming, then the diagnosis is syringomyelia. Pain is lost, but touch is present. Dissociated sensory loss. Classic example is syringomyelia. Right. Having known the basics, the basic concepts of sensory sensations, now we shall move on to the joy of clinical localization of sensory abnormalities, the indispensable concepts. So we'll start peripherally from the peripheral now and then ascend up slowly to the cortex. Peripheral now. So if there's a site of the lesion is the peripheral now, what are the sensory findings, what are all the other neurologic abnormalities, and what is the classic example. Peripheral neuropathy, the classic example is diabetes. Diabetes is one of the most common cause of peripheral neuropathy. So any person who comes with symptoms suggestive of peripheral neuropathy, we should always think of diabetic neuropathy. Peripheral neuropathy. Again, we have small fiber neuropathy, large fiber neuropathy. Small fiber neuropathy, there is a reduction of pinprick, that is pain, and reduction of thermal sensations. So pain and temperature, if it is affected, it is small fiber neuropathy. If it is a large fiber neuropathy, there is a loss of vibration sense and joint position sense. So because of that, there is imbalance. They have absence of tendon reflexes because they take part in the deep tendon stretch reflex, and there is dysfunction of the motor system. So motor dysfunction. So if it's a large fiber neuropathy, they have joint position vibration sense being affected, they have imbalance, they have motor function being affected, and they have absence of tendon reflexes. The sensory deficits of peripheral neuropathy are generally distal, length dependent. So distal part, that is the hand and feet, are affected. It is graded. the most distal parts are more severely affected, followed by the less severe affection of the proximal parts, and when it ascends it becomes still more normal. So the distal parts are more affected, and then as it ascends up, the severity becomes decreased. So this is known as a graded sensory loss. Usually it is symmetrical and it is length dependent, so distal more than proximal. So the sensory loss deficits are generally graded, distal and symmetrical in distribution. Since it is length dependent, when the sensory loss or dysesthesia has reached till the level of the knees, once it reaches the knees, then the fingertip should get affected, because if it's length dependent, so when it ascends from the feet to the knees, it should start affecting the hands and starts moving upwards also, since it's length dependent. Very important clinical point. So if a person says he's got dysesthesia till the thighs and above, but upper limbs are intact, you should be skeptical about his complaint, because once the dysesthesia has reached from the feet till the knees, the fingertips should start getting affected. The other neurological abnormalities in a peripheral neuropathy are distal motor atrophy, distal muscle atrophy, there is weakness, and there is areflexia. The classic example is diabetic neuropathy. Root. When the root gets affected, there is a loss of sensory abnormalities in the root. So dermatomal distribution, there is a weakness in myotome distribution, and there is segmental hyporeflexia. Examples are like L5 radiculopathy or S1 radiculopathy. Plexus. How do we suspect plexus? The sensory findings are that there is sensory loss in the distribution of 2 or more peripheral nerves. So if the distribution is not confined to a single nerve, if the distribution of sensory loss is present in 2 or more peripheral nerves, we have to suspect plexus. Likewise, the weakness also and atrophy also will be in more than 2 peripheral nerves. The classic examples is brachial plexopathy, either due to trauma or inflammation. Next is the spinal cord. So how do we diagnose whether the spinal cord is affected or not clinically according to the sensory loss? When the spinal cord is affected, all the sensation below the level are affected. Spinal cord is a very small in cross section, and therefore all the tracts are close together. So when they get affected, all the sensations below the spinal cord are lost. There is hyperesthetic band at the level of the trunk, which suggests the highest level of involvement. There could be motor function and sphincter disturbance. Since as I said, motor, sensory, sphincters, all the fibers are close together. So loss of all sensory tracts, loss of motor, loss of sphincter. There is hyperesthetic band if it is a truncal lesion. There are some characteristic syndromes which affect the spinal cord and produce a very interesting clinical findings. One, as I said, syringomyelia. If the center of the spinal cord gets affected, the crossing spinothalamic tract gets affected, but the posterior column is spared. So the sensations carried by the spinothalamic tract, mainly pain and temperature, are affected, but sensations carried by posterior column, that is touch, position, joint, vibration sensors, are intact. So touch is present and pain is lost. So person is not even able to appreciate if he keeps the hand in the fire. That is syringomyelia. So dissociated sensory loss, pain and temperature are lost, touch, position, joint, vibration sensors are present. That is syringomyelia. Second, we have the Brown-Sequard syndrome, hemisection of the spinal cord. So when there is a hemisection of the spinal cord, posterior columns and pyramidal tracts which do not cross at the level of the spinal cord, they cross at the level of the medulla oblongata. So when there is a hemisection of the spinal cord, the posterior column and the pyramidal tract, the manifestations are on the same side. But since the spinothalamic tract crosses immediately and goes to the opposite side, when there is a hemisection of the spinal cord, the spinothalamic tract manifestation, that is pain, temperature, are affected on the opposite side. So the spinothalamic tract sensations are affected on the opposite side, but posterior column and pyramidal tract are affected on the same side. That is Brown-Sequard syndrome. Another interesting finding is Lehermit's sign. When there is a posterior column involvement at the neck cervical cord, and when we flex the neck, they will have electric shock sensations going down the spine. So it indicates that the posterior column is affected at the level of the neck. It could be cervical spondylosis or multiple sclerosis or any radiation therapy to the cervical region. So the other findings, neurological findings, are they have paraplegia, they can have quadriplegia depending on the level of the lesion, they have Babinski's sign, and they have hyperreflexia. The classic examples are syringomyelia, which presents as dissociated sensory loss, Brown-Sequard syndrome, and subacute combined degeneration of the cord, vitamin B12 deficiency, which affects the well-myelinated fibers. So if it is vitamin B12 deficiency, it causes demyelination. So of these three tracts, posterior column, pyramidal tract, and spinothalamic tract is least myelinated. So vitamin B12 deficiency does not affect spinothalamic tract. It affects posterior column and pyramidal tract because they are well myelinated tract. So in subacute combined degeneration, which is because of vitamin B12 deficiency, posterior column and pyramidal tract are more affected, spinothalamic tract is least affected. Then we have the brainstem, especially the lateral medulla. When the lateral medulla gets affected, the ipsilateral descending trigeminal tract is affected. Ipsilateral descending trigeminal tract is affected. So the sensations of the face, the painful sensation of the face are lost on the same side because of the ipsilateral descending trigeminal tract. Along with it, there is an ascending spinothalamic tract involvement also. So pain and temperature are lost on the arm and the torso. So facial painful sensations are lost on the same side, whereas the pain and temperature sensations are lost on the opposite side. The facial sensations are lost because of the involvement of the descending trigeminal tract, and the pain and temperature are lost on the opposite side because of the ascending spinothalamic tract. So if these are the kind of sensory abnormalities, we should always suspect brainstem lesion, the lateral medullary syndrome. And brainstem signs, they'll have ipsilateral cranial nerve palsy with contralateral hemiplegia. Classic example is posterior circulation stroke. Then we have thalamus. Here the posterior column and spinothalamic tract both unite at the level of the thalamus, and therefore if there is a thalamic lesion, there is a hemisensory loss involving all kinds of sensations on the opposite side. Sometimes there could be a dramatic painful condition known as Bedridden Rosy syndrome, where there is unilateral dramatic pain on the opposite side. Motor involvement may or may not be there depending upon the tracts involved in the thalamus. For example, dento-rubro-thalamo-cortical tract, if it gets affected, obviously there will be features suggestive of motor involvement. Usually they are lacunar infarcts, thalamus, or it could be thalamic hemorrhage. The other sites of classic hypertensive hemorrhage other than thalamus is putamen, pons, and cerebellum. Then we have cortex. When the parietal cortex is affected, the cortical sensations are lost, but primary sensations are intact. Namely, tactile localization, 2-point discrimination, bilateral, simultaneous stimulation, graphistisia and stereognosis are lost, but touch, position, joint, vibration sense are present. That indicates that the parietal lobe is involved, or cortical lesions. So the other neurological findings which may be forthcoming are contralateral hemi-neglect, contralateral hemi-inattention, not to use the affected hand and arm. Parietal strokes are the ones which affect the cortical sensations. Finally, very important, very interesting is psychogenic. Lot of people crave for attention-seeking behavior, or to avoid medico-legal complications or any legal implications. So they come forward and say that they have sensory loss, but actually they do not have any kind of sensory disturbance. So how are we going to evaluate this psychogenic sensory loss? One, the sensory loss, what the patient says, is difficult to explain in terms of neurological anatomy. For example, midline loss of vibration, midline loss of temperature, midline loss of touch sensations. Second, since the patient does not know the anatomy, they may say that the sensations are lost both above the clavicle and below the clavicle, but the sensations over the upper limb is intact. This cannot be explained neurologically because above clavicle it is C4, below clavicle is T2. So if C4 is affected and below the clavicle T2 is also affected, then all the roots, intervening roots between C4 and T2 also should get affected there, and they should have sensory loss over the upper limb. But if there is no sensory loss over the upper limb, only the sensory loss above clavicle and below clavicle, that means again it is a psychological manifestation. The third very interesting is that the person may say that the right side there's sensory loss, or a right thumb there's a sensory loss, left is intact. So take the patient's hands, put it on the back and twist it confuse the patient. Now ask the patient which hand or which particular finger is affected. He'll be confused because the hands are at the back and it is in a twisted position, so he'll not be able to tell it correctly, and therefore it is psychogenic. If it is organic, still he'll be able to tell it correctly because it is in organic manifestations. So these are the indispensable concepts of clinical localization of sensory abnormalities. I hope you have enjoyed listening to my lecture as much as I have enjoyed delivering it. If you have any suggestions or comments, kindly post on to my YouTube channel, Dr. Sreenivas Medical Concepts, and my FB page, Dr. Sreenivas Concepts. And please like and subscribe my YouTube channel. Thank you. Bye.